So I'd like to, without further delay, invite our second speaker, Professor Quarraisha Abdool Karim. And firstly, I'd like us all to congratulate her for receiving the Virchow Prize for 2025 for her recognition in pioneering contributions to HIV, global health, and equity. We are in the presence of royalty, but she's asked me not to mention that because of when you put people on pedestals and issues related to tyranny. I'm supposed to read your bio. So Professor Karim is globally recognized infectious disease epidemiologist and co-founder of Quarraisha, where she's an associate scientific director and holds the John C. Martin Chair in Global Health. She is also a professor at Columbia University, president of the World Academy of Sciences, and UNAIDS Special Ambassador for Adolescents and HIV. Her pioneering research showed that antiretrovirals can prevent sexual transmission of HIV, laying the groundwork for pre-exposure prophylaxis. Over 3 decades, she has advanced HIV prevention technologies for women and contributed to understanding HIV-TB co-infection and COVID-19's impact on people with HIV. She serves on advisory boards of PEPFAR, WHO, and others, and has trained over 600 African scientists. With more than 300 peer-reviewed publications, she's a fellow of several national and international academies and the recipient of over 30 major awards, including L'Oreal, UNESCO Award, the Canada Gaydana Global Health Award, and the Alaska Bloomberg Public Service Award. She's a member of the Eastern and Southern African Commission on Drugs. Welcome, Professor Karim.
Thank you very much, Eva. I thought I'd come up. You did say it's a graveyard shift. And I'm really pleased to have a good number of people in the audience. I think it speaks to your commitment on the topic. So greetings, everyone, and Klaas and Eva, thank you very much for moderating, for that very warm and generous introduction. Now, you've just heard from Gesine around cost effectiveness. I've been asked to talk about sustaining harm reduction amidst political and financial uncertainty. Now, for those of you who know me in HIV, I work largely with adolescent girls and young women, so I am no expert on this topic. But I do find myself in certain spaces. And from all of these titles over here, the one really of importance is I've been a commissioner on the Eastern and Southern African Commission for Drug Use. And I just want to talk a few minutes about that commission because it was set up about 3 years ago. It includes 3 former presidents from East and Southern Africa, a former High Court judge, and myself. And we have had many consultative meetings in the region. And each time we've gone to a country, we've been very nicely hosted by the president of that country or the person in highest office. And that was very important for the harm reduction agenda because they then had a press conference. And 2, is that we could open up the space and conversation for civil society and people working in NGOs and the very small number of people in this region working on harm reduction, and that we could learn from the lived experiences and understand what the issues on the ground are. Secondly, it involved many government departments, so it moved the conversation from just looking at some of the medical options to bringing in some of the issues related to policing, safety, and the judiciary, and other related departments. As we know, a lot of drug use is very closely intertwined with corruption, with organized crime, with human trafficking, and a whole bunch of issues. And thirdly, we brought the science and the evidence in because we believe robust evidence is important for decision making. And part of that was also in bringing academics in, thinking about the skills and training that's needed. And I'll come back to all of that. But I just wanted to make 3 comments just in terms of context. And the first is that while I may not be an expert in harm reduction, I think I have, in my 65 years, lived through some very adverse conditions. The first is I was born during the apartheid era. So being an anti-apartheid activist for most of my young adult life taught me a lot of things about adversity and what you have to do when faced with bullies and tyrannies and all kinds of other things. So when your dignity and your rights are violated, how you respond to it, 1. 2 is in the midst of a maturing HIV epidemic, our second democratically elected president chose to challenge whether HIV causes AIDS. And thirdly, during COVID, I think all of us, regardless of where we all experienced an anthropological rupture that we weren't prepared for. And my point around challenging times and adversity is in life, there are ups and downs. And if we didn't have those ups and downs, I don't think we would have progressed as much as we have as human beings. And what's important about downs and challenges and failure is not that you roll over and die, but that how you respond to those challenges. And that type of resilience, when you think about it as opportunities, I've learned over 18 years of trying to find women-initiated technologies. And I had the moniker of an expert in failure. Whenever I went to an AIDS meeting, people, oh, here comes the experts in failure. It took us 18 years of failure before we had the first proof of concept. The second point I want to make is an important principle that we've learned in HIV, which is leave no one behind. So it's how we value life, and the value we place on people, on human beings, is not simply about return on investment, nor is it what it contributes to the GDP, nor is it only about what you get and how you spend, because every life is important, and as soon as we start to differentiate whose life is more valuable than somebody else's, I think we're on a very slippery slope. My third point is around HIV, and that in the 40 years of responding to HIV, we faced many challenges on that pathway, and it took us nearly 25 years before we saw antiretroviral treatment change the face of AIDS from one that was inevitably fatal to one that's now chronic and manageable. It took us another 10 years to make that equitable. So there's a whole bunch of lessons there around bringing costs of drugs down, etc. But that evidence in itself is only the first step. It's getting that to people who will benefit most. And with global solidarity, largely catalyzed by science and activism, we've been able to change that trajectory. And we now have a large number of people on treatment. We still continue to see new infections. But what we've done to date to get to this point is not what we need to do to end this pandemic. And we call this last mile of that 600,000 deaths, about 6 million new people who still need to be initiated in treatment, and the 1.3 million new infections that we continue to see. They're not taking place evenly across the globe. They are taking place in very specific areas geospatially, very specific populations, and with this whole array of interventions we have, how do we use that optimally and don't go for a one-size-fits-all approach, because really, do we need a one-size-fits-all? We have to think very carefully about where infections are, where the issues are, what's driving those infections, and what combinations of interventions that we have available is needed to actually make a difference and alter our trajectories. My last introductory point was around diagnostics, therapeutics, and prophylaxis. And I think in HIV, while we have a whole array, in harm reduction, we have a few. It's way behind. And just to say that having those interventions have enabled us in some instances, particularly in therapeutics, to bring the price down. And there's some important lessons there about bringing prices down. The second is we've not made major changes on diagnostics, but we do have point-of-care testing, which kind of changes things a little bit. And then we have prophylaxis. And I think this is on price points, one of the more important lessons where with the lenacapavir, we've gone from working in the dark to actually bringing that down to about $20 a dose, which means for 2 6-monthly injectables, you're talking about something that's less than what the cost of daily oral combinations of tenofovir and emtricitabine is. So I'm going to talk about now this presentation and watching time very carefully about polycrises and why sustainability matters. Then draw on the Global Commission on Drug Policy, the Eastern Southern African Commission, and share with you some pathways that we've been looking at in terms of sustainability, and then the economic and governance case and the need for political reforms, etc. So I think I've spoken a lot about this. I think you've heard this many times. We're all preoccupied with the convergence of multiple challenges that we're facing. And on top of that, what we're also seeing is shifting donor priorities. And I want to say one point on shifting donor priorities. I want to really thank the American people and the American government for PEPFAR and the money they put into Africa for treatment access, and also their investment in the Global Fund for AIDS, TB, and malaria. But in Africa, most of our healthcare delivery is funded by government through public sector facilities. And while PEPFAR played an important role, it's not a forever cash box. And countries like South Africa already started to transition in terms of, like if you have diabetes or hypertension, we don't go with a begging bowl for someone to put money into it to treat people. We do that with taxpayers' money. And I think this is an important point to think about. What we're seeing in substance use, so a lot of the focus on HIV has been on sexual transmission. It's the most dominant form of transmission. It accounts for most of the infections that we see. But in recent times, we've seen an increase in substance use in sub-Saharan Africa. In Southern Africa in particular, alcohol use rates have been particularly high, accounting for about 50% of what's consumed in the rest of the world. But what we've seen now is a lot more cannabis use and then an expansion of opioids and injecting drug use, and we're also seeing synthetic drugs coming in. And I have to say this very loudly, in that this part of understanding substance use, of understanding solutions for substance use, and coming up with programs is probably the most underfunded that I've seen anywhere in the world or with anything. So that's the first problem that we have. And there's a kind of thing like maybe it's going to be somewhere else. It's a very small contribution. I think what people don't understand is with injecting drug use, network transmission rates are very high. And I'm glad Stephanie is speaking after me because she's going to tell you all the facts around substance use. But we also have personal use, and there's this tension between the war on drugs and a more human rights approach. And there's a whole bunch here that we can talk more about. So when we talk about sustainability, I have to say, we have to talk about it in the context of already very fragile responses for harm reduction. Secondly, it's largely dependent on donor aid. And as Jazine just outlined for us, there's very little domestic budgets allocated to this. This is not something that can continue, and I think we have this common challenge when it comes to preventive and promotive health, is that we tend to focus on morbidity and mortality and prioritize that. Well, before you get to being sick and before you die, you actually have to acquire something. And so we got to put more attention to preventive and promotive health. And then we have political turnovers, and where aid is also linked to politics and science diplomacy. So if you want to buy into war on drugs, more aid flows. If you want to take a more human rights approach, the coffers are empty. So there's a problem depending on who's in office in different countries, and it's not institutionalized. Most of the care that we see in sub-Saharan Africa is being done by civil society, it's being done by NGOs, and it's being done by, if I have to use American currency, by nickel and dimes. So if we want to do this, we have to put health and community safety first, 3 pillars. We have to ensure equitable access to controlled medicines, because the whole thing about opioid addiction and so on, what happens is palliative care suffers, pain management suffers, and so these restrictions in some areas are also compromising healthcare in other areas. And then it's about ending criminalization of people who use or possess drugs. So I want to make 3 points here, which is we need to link harm reduction to human rights and the Sustainable Development Goals 3, 10, and 16. And if you don't know your SDGs, bit of homework there to go and check that. It's about a whole bunch of things on partnerships and health and so on. We also need to promote a whole of government approach, and I would extend that to a whole of society approach. This is not a challenge that can be taken up by any one government department or anything like that. It needs an all-of-society approach, which is civil society, academia, NGOs included in there, and also industry. As we know, we need therapeutics, diagnostics, and prophylaxis. And it needs to be embedded within a broader resilience agenda and not forgetting about equity. So the first pathway about putting health and human rights and community safety first is that we know already this can't be in mainstreamed healthcare delivery system. It's already under a lot of pressure, and the harm reduction is politically contested. Often aid is linked, as I've said previously, at least 3 times, on the war on drugs versus a more humane and human rights approach. So we have to embed it within national health plans. There's no getting away from it. We got a problem, we got a big problem, we got a complex problem that's just growing. And that we have to integrate this into existing services. We already have strong HIV services, we have strong TB services. We've seen an increase in MDR and XDR TB. Who's defaulting in medication is the people who are using drugs, who also have to deal with the complexity of social and health challenges such as homelessness, food security, all the rest of the things that we hear and keep hearing about. It has to be in a system that survives leadership and funding shifts. We have to invest in communities who are delivering services. We have to think about differentiated care services where there's a lot of task shifting. We have to learn from lived experiences. Who knows better what to do and what's needed than people living with HIV and who are using drugs. And so there's a couple of things around integration we can look at, around outreach and sustainability. The pathway 2 is about equitable access, and we got a lot of issues around palliative care. There are many parts of Africa where people are suffering because they can't have access to particular categories of pain medication because of the war on drugs, and how do we protect that amidst enforcement-driven restrictions. And I think here, in Pathway 2, we've learned a lot around between COVID and HIV, around pool procurement, regionally to lower costs, about integrating opioid access into universal healthcare packages and national essential drug lists. I mean, there's only a handful of countries that have substitution therapy on the essential drug list. We've got to fix that. We have to prevent diversion through training and accountability, not through punitive bans, and we need to align with the number of frameworks that we already have in place. Key issues about ending criminalization. Political leaders resist decriminalization due to populist pressures. We also tend to incarcerate users and let the drug lords run free. And they also fund political parties, as we know, and all of the other things that are going out. We have to build an evidence-based case. So when Jazine does her next projection, she has evidence on which she's doing it, which shows the benefits of social and fiscal benefits and reforms for the interventions we need to be doing. And that we know if we just take one cost, which is incarceration, it exceeds treatment and prevention investments. Decriminalization reduces prison overcrowding, and we need to redirect policing towards trafficking networks, not people who use drugs. And we need to reform framed as cost-saving governance, not leniency. So there are some opportunities with cannabis regulation and legalization to introduce wider public and civil society dialogues. There are also a whole range of non-partisan structures and expert bodies, such as the Eastern and Southern African Commission, that will help sustain evidence-based policy. And we need to champion regional solidarity in South-South learning to weather political cycles, and probably we can even do some South-North learnings in this. So I'm just going to skip. I think I've covered those issues. But just to talk about, right now we have the Global Fund for AIDS, TB, and malaria. The 8th replenishment discussions are underway. Substance use is very closely linked with HIV, TB, less so on malaria. In the current financial crisis, we've seen new partners coming in, new countries that are making country-level commitments. We're also seeing more philanthropies coming to the party. And so the overall plan in this 8th replenishment for Global Fund is about sustainability, but sustainability not with overnight funding cuts and shutdowns, but really about sustainable transition in a responsible manner where country ownership is transitioned. We need to extend the ARV success to harm reduction medications. We need affordable price. We need affordable price points. We've just done that for oral and long-acting ARVs. Why not for substitution therapy and all the options that are growing, even long-acting there? We've done that between North and South with two-tier pricing. We've done that with voluntary licensing that also facilitates and supports regional manufacturing and production. And we've done it through supportive regulatory and policy frameworks. So we know this. We know this. Why are we not using it in harm reduction? So let's get going with our activism and advocacy there. To build resilience, we need strong institutions. We need a diversified funding base where we're not dependent on one country and handouts. And I should say that that aid, and it shouldn't be seen as charity at this point in time when we're on the brink of an existential crisis. You have to think about it as security, and you have to think about it as a strategic investment. We need to develop better surveillance systems. We finally have a very watered-down pandemic treaty. We need to think better about how we do surveillance. How do we do better monitoring of what's coming in? We're like in the dark about the synthetics that are taking over. So harm reduction and substance use in sub-Saharan Africa had a late arrival. We went from conduiting the staff to it staying here, but we've been using, and the spread has been like on steroids. So that's something we all need to appreciate, understand, and that we have to foster an all-of-society approach and lived experiences, who is delivering services at the moment. But we also need to bring in more researchers, more evidence, more robust evidence, and also academic institutions that train the human resources we need. Thank you very much. I wanted to end on an African proverb, because at times of adversity, we think a single person is ineffective. There's an African proverb that says, if you think you're too small to bring about change, you clearly have not spent a night with a mosquito.